Thank you. Thank you very much, and good afternoon to everyone. Welcome to Houston. For everyone who may not be familiar with Texas, it's always my great honor to speak at the ThyCa meeting. I went back and looked at my history, and I've spoken since 2008 at this meeting all around the country, and I'm so glad that's been in Houston for the last couple of years. Makes our travel a little easier. But I know many of you all in the audience and maybe some of you guys who are online. So thank you for joining us today. Now, if you have come to my talks before, some of this might really be redundant, but sometimes repetition really helps. But also for the folks who are new to this journey on medullary thyroid cancer, I was hoping I could answer some questions. So yes, this is the first part of my talk. The other talk today will be more on systemic therapies or other focal treatments that we have for medullary thyroid cancer patients. So let's get started. Here are my disclosures. So the questions I hope that we can answer today, and there's no way I can read that on the little screen over there. So pardon me if I have to turn back a little bit. So especially for those who are relatively new to this diagnosis, what is MTC or medullary thyroid cancer? What do we mean when we say a germline versus a somatic mutation? How do we assess for the extent of disease that a patient may have? What are some possible predictors that we have to estimate what the disease behavior might be in the future? What treatments are considered early on in the disease course? When do we need to consider other therapies? And can I take this weight loss medicine? It's a very common question that I get now. I think if you watch TV, you can't but get hit over the head regarding these weight loss medicines. I know you probably had a great talk this morning with Dr. Khan, who spoke on weight loss medicines. So as I said, we'll have a separate talk on the spectrum of therapies following this one. So some of y'all may be familiar with the fact that medullary thyroid cancer is one of the types of thyroid cancer. And really the most common type are what we call the differentiated thyroid cancer. That means that these were cancer cells that started from the thyroid follicular cells, which are normal cells that we all have, and it helps produce our thyroid hormone. So we have papillary, follicular, and now oncocytic thyroid carcinoma is a new category, but we've always had it. It's just renamed. But medullary thyroid cancer represents 1% to 2% of all thyroid cancer. So think of it how you will, but you are in a very special, rare population. Anaplastic thyroid cancer, even more rare and much more aggressive than the other malignancies. With medullary thyroid cancer, I still consider it a relatively young disease in terms of what we understand about it. It was first described in the literature in 1959, and we have about 1,200 cases diagnosed new in the United States per year. And again, this is a thyroid cancer that does not start from follicular cells. It starts from these C cells, C standing for calcitonin producing parafollicular cells. And they really just happen to be in the vicinity of the other thyroid follicular cells. And they're derived embryologically from the neurocrest cells. So we do consider this a neuroendocrine tumor. And because they're not really interacting with the thyroid follicular cells, we don't treat this type of cancer with TSH suppressive therapy. So papillary, follicular, oncocytic, we do think about giving patients extra thyroid hormone to suppress their TSH. We don't do that with medullary thyroid cancer. Additionally, we don't treat medullary thyroid cancer with radioactive iodine because these parafollicular C cells, they don't have the apparatus to absorb radioactive iodine. Okay, so I even now today, I still see some patients who come to me where they had received radioactive iodine thinking that might be beneficial. Anytime we think about medullary thyroid cancer, one of the first things that we think of is this hereditary or is this not hereditary, or what we would say sporadic? And hereditary, out of all medullary thyroid cancer patients, about a quarter of those patients will have the hereditary syndrome, meaning that you would have inherited a mutation of the RET proto-oncogene from either mom or dad, 50-50 chance of passing it on to offspring if you by chance have this mutation. And if you have this alteration, there is a syndrome associated called multiple endocrine neoplasia type 2, or MEN2. And there's two subtypes of that, MEN2A and MEN2B, which I'll describe later. Now, when we think about this syndrome, because it can lead to other endocrine tumors, we always ask our patients, is there a personal history or a family history of not only thyroid cancer, but hypercalcemia, kidney stones, easy fractures, parathyroid disorders, um, early onset hypertension that might suggest a pheochromocytoma, which is that adrenal tumor so associated with the MEN2 syndrome. Now, if you find that there's absolutely no inkling of these other tumors in the patient or the family's history, you should still do genetic testing, because about 7% of those patients with no family history or personal history of other endocrine tumors, you'll find that there is that mutation of the RET gene. And I have here throughout the lecture things that are highlighted in green, trying to give you some definitions. So sporadic, it means not hereditary. And then germline means that this was a mutation that was in the germ cell. So eggs and sperm are what we call germ cells. So that's what it means by germline mutation. So in all of our patients with newly diagnosed medullary thyroid cancer, we recommend it as standard of care to see a genetic counselor and get genetic testing. If you don't have access to a genetic counselor, your doctor should still be able to send off your blood or saliva off for genetic testing. So there's really no reason not to do it. And also, if there are online ways of getting in touch with a genetic counselor if you wanted that more highly specialized counseling. And one of our genetic counselors, Ms. Catherine Skeffis, will be speaking later this afternoon. So please ask her your questions if you have any. Now, the MEN2 syndrome, this is a autosomal dominant inheritance, meaning, again, only one parent needs to have this mutation, and there's a 50-50 chance because you, in your eggs or your sperm, half of your gene will be in that packet. So there's a 50-50 chance of passing it on to offspring. And this is a activating point mutation of the RET proto-oncogene, and it encodes for this receptor called RET. So even if you don't have the hereditary medullary thyroid cancer, do make note of this RET receptor, because we're going to talk about this quite a bit when it comes down to all patients with medullary thyroid cancer. So the MEN2A used to be called Sippel syndrome. This is the most common of the two subtypes of MEN2 syndrome. MEN2B is less common. About 5% of the hereditary patients might have this mutation. It's interesting to note that with MEN2B syndrome, the mutation could be de novo, meaning it is the first time seen in this family. This patient is the first one to have it. If you test both of their parents, they don't have the mutation. Sometimes these genetic mutations have to start somewhere. So 75% of the MEN2B patients have it de novo. So their parents have no signs or symptoms of the MEN2B syndrome. This is a cartoon distinguishing the two MEN2 syndromes, 2A on your left, 2B on the right. So they're all characterized by medullary thyroid cancer. And in both syndromes, 50% chance of developing pheochromocytoma, which is this adrenal tumor that overproduces adrenalins. And adrenalins are our ways to kind of escape the tiger that's chasing us in the forest, right? So when you're on that roller coaster and you're scared to death coming down the hill, you have an adrenaline rush that's coming from your adrenal glands. And when people have pheochromocytoma, that excessive adrenaline production causes people to have these episodes of sudden headaches, heart pounding, blood pressures going up, and they turn pale as a ghost. And then the distinguishing features between these two syndromes is that the MEN2A patients have a risk for hyperparathyroidism, where these little glands sitting behind our thyroid called the parathyroids are abnormal, they're tumors, and they overexpress parathyroid hormone, and that pushes our blood calcium to go up. It's leaching calcium out of our bones, and that can weaken our bones, leading to fractures or osteoporosis. It leads to the high calcium in the blood that leads to kidney stones, and so these patients can also feel bad because of the high calcium with nausea, vomiting, constipation. So that's seen in about 20% of the MEN2A patients. But the MEN2B patients, they don't have hyperparathyroidism. Instead, they have a very typical abnormality of their mucosal surfaces. So these are like the red parts in your mouth, the mucosa, your nose, and your eyelids. They get these little lumps called neuromas. And so mucosal neuromas can be seen. And so when you see a patient with MEN2B, sometimes there's very distinguishable by their eyelids turning outward, their nose is a little bit more bulbous, lips are very thickened. If you have them stick out, their tongue is very lumpy, bumpy. But these neuromas, ganglion neuromas, can go through the intestinal tract and actually lead to a lot of problems with constipation and abdominal bloating and discomfort. Just a little bit more about MEN2A. There are some variants, meaning that there's, depending upon the mutation, there might be some other findings that go along with it. So one is MEN2A with Hirschsprung's. So this usually happens with people have a RET mutation that's affecting 609, 611, 618, or 620. And if you really probe into the history, you'll find out that when they were little babies, they didn't eat very well, had a lot of problems with constipation, didn't pass stools, maybe were not growing and hitting their milestones properly, in and out of the hospital because of poor feeding. And it really takes that really acute, insightful pediatrician to think, there's something unusual here. Let's look for an underlying abnormality. MEN2A with cutaneous lichen amyloidosis. So this is predominantly associated with patients with the Rett germline mutation at 634. And it's this very classic area right behind the shoulder blades on the upper back where there's this patch of itchiness. And it's not tumor in the skin. It is literally just amyloid, which is a protein depositing right behind on the upper back between those shoulder blades. And it's very itchy. And the more you scratch, the thicker the skin gets and the itchier it gets. So the best thing we have to tell our patients is don't scratch. And also try to get your friend or family to put on some lotion so it doesn't dry out, because the more dry it gets, the more itchy it gets as well. So actually, this is a very interesting story that, so I see quite a few patients with MEN2 syndrome, and I kind of know when they have a 634 mutation based on history, but I sometimes have the luxury of already knowing they have the mutation. So I go in, and while I'm talking to them, I was like, so how's the itchiness on your upper back? And my patient's like, you're the first one to ever ask me that. No one else knew this thing. And I'm like, yeah, it's a pretty common thing to see. There have been some rare reports in a V804 germline mutation patient with the CLA as well. This is what we mean when we say that our MEN2B patients have a very classic look. So in the middle of the picture, you see this young man with his thyroid mass, but you can see his eyelids are a little bit more pronounced. His nose is a little more bulbous. You can see that on the pictures of the two patients on the left. Lips are much more thickened, and you can see the tongue with the lumpy bumps in that area. Additionally, these patients, really interesting, they don't make tears. They can cry, they can feel emotion of sadness, but when they're sad, they're not making tears. It's very interesting. And then these patients can also have what we call a marfanoid appearance. Basically, they're very tall, very long arms. They go past almost mid-thigh with their arms, and their hands, very long, spindly fingers, a lot of flexibility with their fingers. They can bend it backwards much farther than any of us. But they also can have kind of a scooped out sternum, what's called a pectus excavatum. They can have very high arches on their feet called pes cavus, high palate scoliosis. But that x-ray on the right is colon. So if you can see here, this is your lung space, and it's being all pushed up by, this is a massive colon that's just all filled with air, and it's pushing that diaphragm up. So very uncomfortable, as you can imagine. And so what does this mutation do? So in the normal setting, RET, which is this receptor that crosses the membrane of these C cells, they have an extracellular portion that helps bind with other receptors like GDNF and GFR alpha. But this, very importantly, in this intracellular portion is this TK1, TK2, which stands for tyrosine kinase. And what happens in a normal setting is, because we do have normal RET activity, is that when RET is bound to GDNF and GFR alpha 1, it leads to a dimerization of these two receptors. And when they dimerize, these tyrosine kinase portions will be phosphorylated and leads to normal cell proliferation migration. But in the MEN2A and 2B patients, what happens is that the mutation is either altering the extracellular portion in our MEN2A patients or the intracellular portion in our MEN2B patients, and it allows for the receptor to dimerize in MEN2A patients without the need of binding to those other receptors, GDNF and GFR alpha. And MEN2B situation, no dimerization is needed. The mutation on the intracellular portion just leads to an activated receptor. So basically the on switch is always on, and it's leading to these cells to be unregulated and continue to divide and grow and spread to other areas in an abnormal fashion. In the germline mutated patients, not patients, but the germline mutation positive patients, we do group these mutations into risk categories. And so the highest risk is a germline mutation of RET 918. Now, I know that many of y'all in the audience will say, I have a 918 mutation, but that's a sporadic mutation, okay? It was not hereditary. So I'm currently talking about germline RET 918 mutation, hereditary mutation. We'll talk about 918 in the sporadic fashion in a little bit. But so the thing about the germline 918 is that it's already activating the thyroid cells to become altered and mutated even while the baby is growing in utero, so as a fetus. And when they are born, they could already have medullary thyroid cancer. And so we documented in the literature the youngest age of onset is a 2-month-old with medullary thyroid cancer. They have the highest risk of metastases spread to other areas. Documented in the literature, the youngest age is a 5-year-old with distant metastases. And these patients do have a higher risk of mortality at a younger age, mainly because they started much earlier in life with their disease, potentially unrecognized for a long time, and had that risk of the disease spreading to other areas and compromising their health. Now, high-risk mutations, there are 2 germline mutations, RET 634 and RET A883F. If there's anything that patients wanted to remember is, of all the hereditary mutations, the 634 germline mutation is the most common one associated with MEN2A, and 883 is much less common. That's usually associated with MEN2B. These patients look like a 2B patient, but they don't have as an aggressive course of their disease as the germline 918 mutation patients. But these are considered high risk because they do have a high risk of metastasis. First report of is a 6-year-old with lymph node metastases. And then we have the moderate risk. So basically, if you're not a germline 918 or 634 or 8883, then any other germline mutation, you're considered a moderate risk mutation. And so this leads to less aggressive medullary thyroid cancer. Patients with this mutation tend to have lower calcitonin levels at the time of diagnosis, and maybe even still disease confined to the thyroid gland, or at most maybe just lymph node metastases. So this is how we characterize these germline RET mutations. And why does it matter? So some patients come to me and say, I'm adopted. I don't have any known living first-degree relatives. I don't have children. So what does it matter if I know if I have the hereditary mutation? Well, it matters to you, because if we know you have a RET activating germline mutation, we could predict if there's a risk for the other endocrine tumors. So this is what this graphic is trying to show you, in that we have patients with the RET mutations of 609, 11, 18, and 20, and then 634, 768, and 804. And then what is their percent risk of having medullary thyroid cancer? You see that's almost 100% for all across the board. But medullary thyroid cancer, you see the highest risk, I'm sorry, that's not medullary, pheochromocytoma, it's the highest risk with 634 RET mutation, hyperparathyroidism with the 634 mutation as well. But as opposed to someone who has a germline 804 mutation, very few reports of association with hyperparathyroidism and pheochromocytoma. So when a patient comes to me and they're relatively young, 25, 28, and they come and say that, yeah, my mom had an adrenal tumor called pheochromocytoma, and they themselves currently have hyperparathyroidism, I'm like, I bet you there's a 634 RET mutation, and lo and behold, there is. So it can be very predictive, and it helps us guide in surveillance of our patients. But also nowadays, by knowing if there is a RET mutation, it might have some consequences towards determining what therapy we might consider down the road if we have evidence of disease recurrence or spread to other areas. So now I'll distinguish a little bit more about germline and sporadic somatic RET mutation. So somatic means that the mutation is in the non-germ cell. So after we're born, our stem cells, they start differentiating. The one cell is going to go down the line of becoming a heart cell, another cell is going to become the kidney cell, and another one's going to become the thyroid cell, right? And so this distinguishing features, they're already committed down this line of differentiation. And so our cells are always in a constant state of division and growth and new growth and dying and such. And sometimes it goes haywire and we can get these mutations. Now, mutations may not cause any problems, but sometimes a mutation can lead to a patch of skin that is discolored, right? But it's not cancer. But sometimes a mutation can lead to cancer. And so for some reasons, sometimes these C cells, after you're born, develops a RET mutation or some other mutation, and it leads to a change of that C cell into the medullary thyroid cancer cell. So we see here the hereditary syndrome with the RET germline mutation, but in patients with the non-hereditary medullary thyroid cancer, if you check their tumors, about 45% of them will have a RET mutation. So again, this is not something that you inherited, but it just somehow developed after you were born. And again, we don't know why that happens. But outside of RET mutations, about 15% can have a RAS mutation, and they can be an HRAS, a KRAS, or an NRAS mutation very, very rarely. So when you take all comers, all patients with medullary thyroid cancer, approximately more than 60% of medullary thyroid cancer, hereditary and non-hereditary, there's going to be a 60% chance of having a RET alteration. So RET is something that's very notable for our patients with medullary. Now, I do want to emphasize this for the patients who come to me and say, Doc, I've already had my testing done. I don't have a RET alteration. And I say, can I see what kind of testing platform that was? And so sometimes they'll show me the good testing for germline mutations, like whether it's a Mayo Clinic or an Invitae or an Ambry or some like MyRisk or something, that's fine. But then they'll say, well, no, I don't have the hereditary, but they tested my tumor and it doesn't have a RET mutation. And when I look, it was tested on what's called a FISH. FISH stands for fluorescence in hybridization situ. And this is checking for what we call RET fusions or fusions. So it's when one part of one gene is fused to another part of a gene. And there are some cancers that have RET fusions. So lung cancer, they can have RET fusions. Papillary thyroid cancer patients can have RET fusions in up to 6%. Anaplastic thyroid cancer, we can see RET fusions, but we don't see RET fusions with medullary thyroid cancer. So if you had your tumor tested on a FISH platform, then we recommend, no, let's do it on a what's called a CLIA certified NGS or next generation sequencing testing platform. And that will be able to analyze the whole gene in that cell to see if you have a mutation in the RET gene. With science getting better, I mean, literally when I started, we only tested for RET 918. As the platforms get better and more sophisticated and higher sensitivity, we are now finding some rare RET deletions where a portion of the RET gene is deleted out, activating that RET receptor. Or we've had duplications where portions of the genes are just duplicated. Again, we don't know why, but there's just multiple runs of a certain pattern within the RET gene in some patients. So more sophisticated tumoral testing has been able to identify these more rare alterations. But again, a fusion is not what we're looking for. There have been some rare fusions identified in patients with medullary thyroid cancer, but that situation is much more rare. And we might send off tumor for a more special testing for RNA sequencing if absolutely nothing else is found and we're really hunting for another possible alteration. Yes, sir.
Table,
yeah,
those numbers add up to 60%. So
no, so this is my math. So 25% of MTC is hereditary. So 100% of 25%, right? And then 45% of the 75% of the non-hereditary is going to have the RET mutation. So when you do that, of all patients with medullary, 60% will have a RET alteration.
I'm looking at the table.
Yeah.
Patient frequency, and I'm wondering, it looks like in 40% of the time, is it 40? In 40% of the time, when tested for mutation, are they not finding a mutation?
Okay. Right. So sorry, I misunderstood your question. I thought you were asking about this 60% down here. So right. So when you add up all these, it's getting to be about 60%. So 30 to 40%, we haven't been able to identify another mutation. This is what's called, again, we think our testing platform is still just not able to pick up the abnormality. And hopefully in another 2, 5, 10 years, we'll have even better testing platforms to identify. But yes, it's negative. Now, what I would say is that in my patients who don't have any identifiable mutation, after a few years, if there's a clinical indication for it, I might run the tumor testing again if I know I have a more sophisticated panel.
And do you have a theory as to whether these are mutations of those 4 types that we're missing or just mutations of something else that
I think it's something else.
Okay.
I think it's of something else.
Thank
you.
Okay.
Yeah. Thank you. How do patients with medullary thyroid cancer present? Often with no symptoms. It just happens to be found because you actually were in a car accident and they can't, they screen you with a neck CT to make sure you didn't fracture anything. And hey, you have some thyroid nodules. Or they had a church health screening and they did ultrasound of the carotids and hey, by the way, you have a thyroid nodule. So oftentimes it's patients just incidentally finding it. But sometimes patients do notice a neck mass. I'll be honest, I think once we start going to Zoom meetings, a lot of people can't help but look at themselves in the screen and they're like, what's that over there on my neck? My goodness. So there are some people who, or even the other way where people are on the talk and saying, what's that on your neck mass? So I was telling people. So Zoom was good for something. And then about 30% of our patients with medullary can have diarrhea. And this is what we call paraneoplastic syndrome. So in certain cancers, the cancer itself can make certain proteins or hormones, and it leads to some abnormal physical symptom. And diarrhea is one of those in medullary thyroid cancer patients where the tumor, because of the neuroendocrine lineage, it can make these other proteins like CGRP, prostaglandins, 5-hydroxytryptamine, or VIP, And these things can all lead to increased gut motility, inability to absorb water out of our gut, so your stools are looser and more watery. And it doesn't always correlate with calcitonin levels. So I always, there's a little bit of a misunderstanding that calcitonin causes the diarrhea. It doesn't. It just happens to be high when patients have the diarrhea, because typically the diarrhea coincides with more tumor burden. And once people have an intervention like a surgery and they notice, oh, my diarrhea went away, well, that was because the tumors were just there and producing other proteins that was leading to increased gut motility. I do find that sometimes the diarrhea is more prevalent in people with liver involvement of their medullary thyroid cancer, but I've seen it with people just having it with significant disease in the neck, and their diarrhea goes away after the surgery. Flushing is another paraneoplastic syndrome. So this is when these tumors can make these hormones or these proteins that, sorry, I meant proteins, that actually causes your blood vessels to dilate. And by doing that, you flush, you turn red. We'll ask our patients, do you have any flushing or any diarrhea for these reasons? So it's interesting because the patients with pheochromocytoma, they can turn pale because the adrenalines make sure blood vessels constrict. So you turn pale. So some patients with MEN2A, they can have flushing because of the medullary, and then they can turn pale because of the pheochromocytoma. So they're going both ways. So these are very telltale signs. Very rarely, the tumor can abnormally produce hormone called ACTH or CRH, and these are natural hormones in our brain, and they pass through our pituitary, and it then goes on to our adrenals to tell it to make cortisol. But sometimes these medullary thyroid cancer cells, they're producing these hormones within the cells, and now you have this exogenous stimulation of adrenal cortisol production. And when cortisol is high, people start noticing excessive weight gain, high blood pressure, potassium is low. They feel very weak, muscle weakness, and also diabetes or even fractures. And then when we check their labs, we can see high calcitonin and also CEA or carcinoembryonic antigen. I still find it surprising that some of my patients come to me after 3 years of diagnosis with medullary, and they only come to me with calcitonin levels. They haven't been getting their CEA levels checked. So this is something that a lot of people forget about. CEA is a very nonspecific protein marker for cancer. It can be elevated in other cancers like lung cancer, colon cancer, gynecologic cancers, but we do measure it with medullary because typically our patients, if they have disease, they make more calcitonin because the C cells still act, the medullary thyroid cancer cells still act like the C cells that they came from, so they make a lot of calcitonin. But CEA is this more primitive protein, and they can make this as well. And I track the calcitonin CA as patients' disease may grow, the calcitonin CA should go up in a similar pattern. And then after an intervention, they typically go down at the same pace in a similar pattern. And when I see that patient's calcitonin's not changing very much, but the CEA is preferentially rising, sometimes I'm concerned about the medullary thyroid cancer changing to a more aggressive form where it's less like the mature cell it used to come from, and it's becoming more immature. And so it's easier for it to make those CEA proteins, and it might indicate that the tumor is behaving more aggressively. Now, when my patients, their imaging doesn't show any disease changing on imaging wise, and yet CA is rising, then I'll try to hunt for other cancers. Have my female patient had a mammogram recently. When was the last colonoscopy? Have the male patients had PSA levels, checking for prostate? So looking for other cancers that might be driving the CEA. So I do always get both of those levels. A little bit about the vagaries of calcitonin. Calcitonin is highly variable. You go to the same lab, same day, and it can be different by many orders. The lower the level, the less changes, but the higher the level, I could see 100, 200, 300-point differences. So we have to accept that it's not like throwing darts at a bullseye. In my hands, it's like throwing darts at a bullseye. I never get into the bullseye every time. So it's never that accurate, right? But so there's going to be that inaccuracy of the lab. Additionally, food will drive the calcitonin up. So I always tell my patients to make sure you have your blood work done while fasting. So no food after midnight. If you do have labs drawn in the afternoon, have a very light breakfast, not high caloric foods, just a little bit of yogurt and some cereal, and then wait at least 6 hours before the lab draw in the afternoon. Additionally, iodinated contrast, so CAT scans that have iodine contrast in it, that can drive up the calcitonin. So I always try to ensure my patients get their lab work done before the CAT scan. Even if you get the CAT scan done and 30 minutes later you get your blood drawn, that can be enough time to drive up the calcitonin. And then I never tell my patients to fast for 2 days before coming in for their blood work, but the 2 to 3 days leading up to the blood work, just eat like your normal self. If you typically have a glass of wine with dinner, go ahead and do that. But don't polish off a bottle of wine with your significant other celebrating a birthday the night before your blood draw, okay? I had a patient who came to see me on a Tuesday. He had his lab work done on a Monday, and I noticed his calcitonin was up like more than 2,000, 3,000 points than usual. And I said, nothing's changed on imaging. What happened? Were you fasting? He's like, I was fasting, doc, but I just was at Napa for a food and wine festival this weekend. I'm like, well, you didn't invite me, and so I'm disappointed. But I get that. But so luckily he was in town for a longer for a week. So he just kind of ate like he normally does. And the following week, I rechecked the calcitonin and was down towards his baseline. So we can't help but monitor our calcitonin and CA levels. We can't help but get stressed when a level goes up or a level what's going on with this level. Do have a little bit of understanding that there's going to be some unreliability, and it's not so much one lab value as much as what is the overall trend, okay, over time. CEA has a lot less variabilities within the same lab, so less of that kind of problem with food or CAT scans and such. Additionally, do not compare your calcitonin or CA levels to labs done outside. Even if it were the same machine, like the company, there can be some differences. I recently had a patient who had a lab draw with their local doctor 1 week prior to seeing us, and our lab value, the calcitonin, was higher. Freaked him out because he thought he had progression within that week. I totally get it. He's new to the disease. But I did a lot of counseling that this is just different labs. So don't get too nervous about that, and compare labs to the same lab where you had it drawn before. Okay, so how do we diagnose medullary thyroid cancer? We want to do it with biopsy. We got tissue is the issue. So that's how we know if a patient has medullary thyroid cancer. Now, sometimes we can have these inconclusive fine needle aspiration biopsies, and so they do further testing. So they can stain for calcitonin, but there is some variability and intensity of how bright it shows up. So the technique of doing that staining may alter the result. You can stain for CA and chromogranin. We look for the absence of thyroglobulin, which is the protein made by the follicular cells. And you can measure calcitonin in any fluid that you draw out from that biopsy. But medullary thyroid cancer can be confused with other tumors. So sometimes if we see amyloid, which is this protein that's associated with medullary, you could see that also with benign nodules that is a colloid nodule. We could see epithelial features that mimics a follicular tumor like neoplasm or even cancer, plasmacytoid features mimicking a plasmacytoma, spindle cell shapes can mimic sarcoma. We have sometimes confusion with papillary thyroid cancer, paraganglioma, lymphoma. And so it's Not impossible to find this situation where the FNA was not really conclusive, and then, the mass might have been big enough and concerning enough that the thyroid surgery was done, and then once they got more tissue, they were able to confirm that was medullary thyroid cancer. What happens if there's another cancer with the medullary in the findings? So not impossible again that some patients, when the tumor is removed, they find not only medullary thyroid cancer, but also papillary thyroid cancer or follicular thyroid cancer. And we really consider this incidental. One tumor doesn't make the other tumor behave more aggressively. So some data is out of this German study is out of over 1,000 papillary thyroid cancer patients, almost 3% had medullary. In the hereditary medullary thyroid patients, about 160 of them, 2.6 had papillary thyroid cancer. And so it's possible to also identify another cancer. But just because there was a papillary thyroid cancer, oftentimes it's the less risky disease when we look at the pathology. So radioactive iodine is not necessary, and it's not going to help the medullary thyroid cancer in preventing it from coming back. Management. So our primary management to take care of the medullary thyroid cancer is surgery. And one, for potential curative intent, especially if the disease has still been confined to the thyroid gland and hadn't had a chance to go outside of the thyroid to local regional lymph nodes. But also because the neck is a very confined space, a lot of important structures in this area, nerves that feed our vocal cords, our trachea, our esophagus. If there's growth, even slowly over time, it can lead to compromise to those important structures. And so surgery is both for potential curative intent, but also for prevention of badness from happening down the road. Now, in our patients who have hereditary disease, if we know that a patient has a germline RET mutation because of family screening, say the uncle was actually found to have medullary, the RET mutation was found to be positive, and now first-degree relatives are being tested. So the patient themselves don't have any symptoms associated with medullary, but you notice that maybe their thyroid has some abnormal looking nodules, or the calcitonin is elevated. So they go for their total thyroidectomy. The idea is that maybe we're capturing the disease earlier enough in its course before it's had a chance to spread to other areas, and it could be potentially curative and preventative of the disease coming back down the road. So that's what we mean by prophylactic thyroidectomy. Not too different from breast cancer patients with the BRCA mutation, and they go for prophylactic mastectomy, trying to prevent disease from developing. In our patients, if you don't know their RET germline mutation, or and you're waiting on that, you can test for pheochromocytoma with lab testing in either blood or urine. And you want to rule out a pheochromocytoma before surgery because, again, pheochromocytoma associated with the MEN2 syndrome can lead to those adrenaline surges. And when you're under the operating table under anesthesia, your blood pressures will surge, and we don't want a hypertensive heart attack or event on the table. So rule out the pheochromocytoma before surgery. But we do recommend waiting for the germline RET test before surgery. And this is where I tell my patients that, of course, no cancer is a good cancer, and we always want it out as soon as possible. But typically, medullary thyroid cancer is a slower disease process, and waiting the 2 to 4 weeks to get the RET germline test back is okay, because it helps the surgeon know if you do have a RET germline mutation, especially a type that leads to hyperparathyroidism like 634. They want to know what those parathyroids look like when they're operating. Where did they, even if they looked healthy, did they leave them behind? Did they look healthy? Because who knows, in the next 5 years, this patient may develop hyperparathyroidism. And so you might have to go back in to remove that parathyroid tumor. So know where those parathyroids were. So knowing the RET germline mutation in our practice is important. Now, Then for all comers with medullary, when they have the surgery, if they already have lymph nodes involved with the thyroid cancer, the chances of getting a cure from that surgery is very low. And this was one of the studies that is a relatively old study, but it's still very valid. So if patients have no findings of abnormal lymph nodes involved with thyroid cancer after their surgery, about 38% will still have evidence of residual disease. So almost 40% with no lymph node metastases will still have some evidence of disease after that surgery, as evidenced by elevated calcitonin or CEA. So that means that there are some microscopic cells that did escape the thyroid, just not well seen, was not removed in any of the lymph nodes that were removed at the time, but they could, over time, show themselves with radiologic evidence of progression. Now, if lymph nodes are already present at the time of the diagnosis, either you see it on ultrasound or in pathology or identify it, then the chances of having residual disease is 90%. So I always tell my patients that I am an optimist, but I also am a realist. And if lymph nodes are involved, it doesn't matter if you're being operated upon, the best surgeon in my group, Dr. Zafario, any others in my group, or the best surgeon in the world, the chance of having residual disease is very high. And I say this so that my patients are not so disappointed when they see what their calcitonin or CA level is 3 months later, 6 months later, 1 year later. And so we just have to set realistic expectations. Now, with metastases, so metastases are when when a cancer cell has spread outside of its place of origin to other places. So metastasis to a lymph node, metastasis to a lung, or to a liver or bone. And metastases are very common at the time of diagnosis in our patients with MTC. The most common location first will be the central compartment of the neck. And so I have a little cartoon here of the compartments in the neck, but the central compartment is this level 6. It's Roman numeral 6 and Roman numeral 7 down here. And that's just the drainage pattern of the thyroid gland. And so 80% of our patients at the time of diagnosis will have evidence of lymph node metastases. So this is not an uncommon situation. And again, it's because it's such a slow growing cancer in the majority of our patients, and it doesn't lead to a lot of symptoms in the majority of our patients. So it's just percolated along for a good while and had a chance to spread to other areas. Now, distant metastases, so distant meaning distant from the organ of origin. So we're talking about lungs, liver, bone, brain. And so 10 to 15% will have distant metastases at the time of diagnosis, presentation, most often in the lungs and liver. In the liver, they often look like blood vessel collections called hemangiomas. And whenever my patients have imaging that says hemangioma, I will follow those for a period of time. And if tumor markers are rising and those little hemangiomas, quote unquote, are growing, those are not hemangiomas, those are metastases. Note those findings. Bone, we can see about 20% of our patients can have evidence of metastases in the bone at diagnosis. Brain, very, very rare. To be honest, we don't screen the brain routinely on our patients because it is so rare. And so that's a good thing. Now, despite what I'm going to say at the next talk, currently we still don't have any options to offer curative intent. So even though we have drugs that are offer good control of disease, it doesn't necessarily cure our patients. And so when patients still have evidence of disease, we're really looking at active surveillance until we see progression. And depending upon the areas of progression or the rate of progression, we might focus on what we call focal treatments, like surgery, like we're just targeting that one area, radiation, sometimes other kinds of treatments that I'll talk about. And then sometimes we have to be thinking about systemic therapies. And systemic means you swallow something or you get injected with something and it goes throughout your whole body trying to get to all of those cancer cells. So systemic therapies, the oral chemo drugs that we are talking about. Now, how do we identify areas of disease? So this is based upon the old 2015 ATA guidelines, and this will be updated somewhat for our 2020 6 ATA guidelines now. It's not 2025. All right. I'll talk. I know you guys have been asking, and so I'll talk about the status of that as well. But so in the 2015 guidelines, it said basically ultrasound is standard. We always recommend that. That's an easy non-radiation associated modality looking for abnormal lymph nodes in the neck. But sometimes we think about CT neck, CT chest, or abdomen, sometimes MRI abdomen. I switch to MRI abdomen sometimes after my CT abdomen because I don't want to overexpose my patients to radiation. So MRI is a non-radiating modality. We really don't think bone scans are very useful. It's very insensitive at picking up bone metastases. So I usually will do an MRI of the spine and follow that periodically. And so when patients have calcitonin levels greater than 500, that seems to correlate with a higher risk for distant metastases. So sometimes you do more advanced imaging for those areas. Now, it did have a recommendation that neither the FDG PET or FDOPA PET is recommended to detect the presence of distant metastases. It's a little more nuanced now. And to be honest, there's a lot of different functional imaging studies, these PETs with all these letters and radiation molecules. But I still agree that FDG PET, which is the most common type of PET that a lot of cancer patients get and a lot of oncologists think of, it's using radioactive glucose. A lot of times medullary thyroid cancer is just a more indolent cancer, and so it doesn't want or need glucose to feed itself, so it may not light up on the glucose PET CT. Now, if you do get a PET CT and there are lymph nodes lighting up, then that's certainly consistent with metastases, but it may not show metastases in the liver or bone because those other sites are more slower growing. So I don't use the FDG PET routinely. If I do anything, I'll typically do a gallium dotatate PET because it binds to what's called somatostatin receptors on the surface of our medullary thyroid cancer cells, and they can help identify additional areas of metastases where my CAT scan or MRIs are missing. Yes, sir. Yeah, actually, so the question is copper 64 dotatate PET. So copper 64 just has a longer half-life. So actually it is similar in its sensitivity as the gallium dotatate. It's really just for convenience. You know, sometimes, you know, when you have like 5 different studies and one study puts you late, now when they dose you with the gallium, they want to scan you really quickly. Copper dotatate, I think there's a few hours that you can wait before you get the scan. So it's just a little more stable for longer periods of time. Yeah. But I don't think, I don't have any data to show that it's better at picking up lesions than gallium dotatate. Yeah. Okay. So I'm just very cognizant. We started at 1:45. It's now 2:40. Okay. We're going to have to go. Yeah. So with patients with their thyroid cancer, if it's still localized to the thyroid gland itself, no lymph nodes are involved, that is the best overall survival prediction, and meaning that more than 95% of patients will live beyond 10 years. But if regional lymph nodes are involved, the 10-year estimated survival is 75%. But if distant metastases are seen at diagnosis, then that drops down to 40%. So meaning 40% will likely be living beyond 10 years. Now, these are just statistics, all right? I've had patients who had distant metastases and I'm still seeing them 15 years later, okay? So statistics are just statistics. And also we have better ways of controlling our patients with their disease. And so I think survival, this helps give people a sense of idea of what's going on, but it's not the end all be all definitive predictor. Okay. Yes. Yes. Yeah. Distant. Right. So the question is, what does regional mean? That means lymph nodes in the neck. Distant is far away from the neck, like lungs, liver, or bone. Okay. Another predictor of activity is this grading system. So this is a lovely study that had 5 centers in the US, Europe, and Australia. More than 300 patients' tumors were analyzed, and these were pathologists that looked at the tumors, and they tried to look for what's called high-grade features. So did the patient's tumor have a high mitotic index? That is when cells are being seen to divide and grow and split into two. If there's a high Ki-67, another marker of activity of the cell, and also tumor necrosis, are cells actually dying? So are they growing and, is their lifespan just more aggressive? And so if you have any one of these things, it's considered high grade. And so what they found was out of these tumors, 75% were low grade. And that reflects what our general population medullary thyroid cancer patients have, is that 75% of our patients have very slow disease, even after surgery, and they still have evidence of disease. But 25% of these tumors had those high grade features. And so high grade features were more often associated with male gender, a larger primary tumor, a higher post-operative CEA. So after surgery, what was the CEA? Distant metastases at presentation or vascular invasion. Now, these graphs are very difficult to read, but I'll try to orient you. So the blue lines are the patients with tumors that had low-grade features. The red line are the patients with tumors with high-grade features. And on the leftmost graph is overall survival. The graph just to the right of that is disease-free survival, and the graph to the right of that is local regional recurrence-free survival, and the farthest right one is cumulative distant metastasis-free survival. So it's indicating how much time lapses before patients develop death, or more evidence of disease, or lymph nodes in the neck, or distant metastases. So what's really clear is that the patients in the blue lines with the low-grade features had much longer time before they had these bad issues like death or recurrences in other areas. Whereas the patients with the tumors with the high-grade features, they had a shorter time before there was evidence of aggressive disease affecting their lives. So this is not something that was used or reported in pathology uniformly. You will find that some of the, over the last 3 years, more and more pathology slides are finding this. So I'm going to, because of time, we do have, so I'm sorry, I do, you guys know me in clinic, I do say a lot of things. I talk a lot. That's why I'm always running behind in my clinic. So let's see here. So I wanted to talk about focal therapy for oligoprogressive Mets, and I'm going to talk on this again at the next talk. But when we talk about focal therapies, it's surgery. It's targeted surgery. Any surgery on the neck after your initial surgery is not for curative intent. It's to control the disease that has popped up and is growing in that region, so we don't want it to threaten those important structures in the neck. Radiotherapy, that's radiation therapy. It's absolutely true. We do not advocate for radiation to the neck anymore. That's what we recommended back in the 90s and the early aughts, but it's not what we would recommend now, because we do have really good treatments like surgery or other treatments available to us. Now, if patients have really advanced disease that's invading the tracheal wall or their esophagus, and my surgeon knows they got as much as they could, but they know there's microscopic disease still in that area, at times we don't want it to progress, maybe some very focal directed radiation instead of the generalized radiation to the neck nowadays. Bone metastases, sometimes we could treat with radiation, and then these other drugs that I'll talk about the next session. So systemic therapy, and we'll go into this more at the next session, systemic therapy are, so if patients are having disease progression in multiple sites, and we can't use focal therapy for all these sites, let's just say lung metastases, we can't keep radiating all those parts of the lung, right? It's going to lead to a lot of scarring. So this is when we need to think about systemic therapies like drug therapy. So this is going to be in the guidelines, in the updated guidelines, because now we can actually tell people what is first-line therapy. If there is a RET alteration, whether it's germline hereditary or somatic non-hereditary RET mutation, we recommend a RET inhibitor. It's clearly a much better drug in decreasing the disease progression, shrinking the disease, but also much more tolerable than the two other drugs that we have. But unfortunately, for those patients who don't have a RET mutation, if they have a RAS mutation, or if they have what we call wild type, no RET or RAS mutation, we recommend cabozantinib or vandetanib. And I know that there are a lot of folks out there who are very anti-vandetanib, anti-cabozantinib, but the drugs do work. And with good education and monitoring and maybe dose starting at lower levels, they are tolerable and sustainable with good education. Can we hold the question for later? Thank you. We'll talk about that. So I'm a Shakespeare buff, so to treat or not to treat, that's always the question that we have. Is this time? Is this time? Maybe not yet, maybe down the road. Sometime it's the writing's on the wall, right? So this is what we typically recommend, is that clearly if disease is progressing, and RESIST is a study-related monitoring tool to measure tumor lesions. So we don't have the time to do RESIST in patients who are outside of a trial, but we kind of know if patients have disease that's growing more than 30% within 6 to 12 months, that's a kind of aggressive in its behavior. So if there's truly structural progression, or if there is symptomatic disease and metastases, but we can't control it anymore with our focal therapies, or if there's bulky disease compromising nearby structures, this is when we would consider systemic therapy. Then the yellow is considerations, people with short doubling times, and they do have evidence of disease in other areas. We might consider that, but really for those paraneoplastic syndromes like the diarrhea or Cushing's, if they're not well controlled by our conservative measures, then sometimes we do think about systemic therapy. Neoadjuvant, Dr. Zafiro is speaking, so he'll talk about neoadjuvant. I think Dr. Hamidi and Dr. Maniakis will also be talking about neoadjuvant therapy. So this was really the hot discussion at the ATA meeting a few weeks ago. The theme was neoadjuvant. So basically our patients who had RET alterations, deletion, 918, 630, by giving them selpercatinib, there was significant regression of disease afterward, allowing for surgery to be more doable. Not for curative intent again, but to prevent like nerve damage or vascular damage or muscle damage. So it was very, very promising. And actually, we're even doing another neoadjuvant study with a different drug in those patients who don't have a RET mutation. So I know time is up, so I'm going to end here. I did have all the things talking about the GLP-1 receptor agonist drugs. Long story short, humans are not mice. And so even though this was found in mice, I don't believe this will happen in humans. I think that anyone who did develop medullary thyroid cancer around the time of them using GLP-1 receptor agonist, probably it was just a detection bias. So that being said, in my patients with active medullary, for now, I do not recommend them getting onto a GLP-1. There's a black box warning. And if my patients have progressive disease on one of these drugs, then I have to eat my words, right? But no, it's more that we're just avoiding this while we're still trying to understand this class of drugs. But certainly my hereditary MTC patients, I would hold off on using any of these. So there are other ways of helping with weight loss. So avoiding this for now in our MTC patients. So I would just like to say that if you haven't already found it, but the MTC Educate webpage is there for you to help enhance some of your questions here. And finally, we're going to do this for tomorrow evening at the dinner, but I just want to say personally, Dr. Gil Cody was one of my dearest friends and mentors. And it's a tragedy that he left us when he did. It was very sudden, but thankfully it was peaceful. But he has done so much for the world of the medullary thyroid cancer world. I know that many of you all actually had relationships with Dr. Cody outside of even this meeting. And just want to say that we will miss him dearly. Thank you very much.
What's the prognosis for sporadic MTC with a calcitonin level of 22 prior to lobectomy and 3 years after has an undetectable calcitonin?
That's a wonderful prognosis. Yes. Yes. Yes.
I have a question about selpercatinib. If a patient with metastatic MTC is currently taking it and all of his tumors have disappeared based on CT and MRI, and he remains stable with no evidence of disease, is there an option to stop taking selpercatinib so that he can have a child?
So you can have a child. Okay. So we do not have any data on what happens when patients stop their drug for any prolonged drug hold. That said, if there are personal goals that a patient wants to achieve, we will try to consider that. And this patient's situation is the best situation for a drug hold because there is no measurable disease. Now, that being said, for men, after exposure to anything that might expose their sperm, we typically recommend at least 3 half-lives of the sperm's lifespan. So about 6 months before any exposure to that. So if selpercatinib was stopped, we would want it to be stopped for at least 6 months before any childbearing potential occurs. I do always have this conversation with my patients if they are childbearing or they even if they're 23, but when they're 30, they might want to have children, to consider sperm banking or egg harvesting beforehand. So these are, you again may never want to have children, but just to have that option available. Yeah.
And this is an interesting question. So a question about biomarkers. This person has negative calcitonin MTC, even with a 2.6 centimeter tumor, was negative for serum calcitonin and CEA. Tumor did not stain positive for calcitonin, so assuming that it did not secrete it. Do you have suggestions for alternative biomarkers to use for monitoring MTC recurrence or progression?
Yeah, that is a tough part. So not often, but sometimes patients have very poorly differentiated disease and they're just not making calcitonin or CEA. We have tried looking at CA19-9 as another biomarker. That's a biomarker for other kinds of neuroendocrine cancer. So you could try that, but even in some of my patients, 19-9 was negative. So really, it's just continuing to look at structural imaging to look for disease progression. Yeah.
And one last question. So we've got someone who's in a rural state with no centers of excellence. Providers have never had a patient with MTC and are kind of at a loss of what to do. And this is the person, I believe, who was negative for calcitonin and CEA before surgery. So what's the best way? Is there any way to get that, those providers connected with experts?
Yeah. So I always say that we are all available to providers around the world. I get emails from people who I've never even met before, but somehow they found me, somewhere. And many of us do this where people will just reach out, cold email us with questions about their patients, and we're happy to answer them. So we would say that their doctors are welcome to reach out to us. Now, that being said, knowing this patient's situation, I might recommend that the tumor be sent at least to a center of excellence that is used to diagnosing medullary, just to ensure that there is still the diagnosis of medullary is most appropriate. Again, just the rural nature and the experience level might be different in that community. Yeah. Okay. Yes. Here.
The survival rate,
Yeah.
you're always hard for me to ask, but you know how it's if they have distant metastases in 10 years survival rate, but isn't it better now that with the new drugs?
Yes, so that's why I was trying to indicate is that that was an older study, and it is likely that with drug therapy, survival is changing. We just don't have any, big studies looking at it right now since the advent of the RET inhibitors. But that's a very good question for us to look at. You're right. Exactly, exactly. Yes, ma'am.
Yes.